Hello, everyone. I'm Jean Birchman, your Executive Director, and we are back with another in our speaker series for the month of October. And today I would like to introduce Dr. Brian Wishart and Dr. Emily Kivlehan, both from Mass General Hospital, who are going to speak with us today about neuromuscular scoliosis, background and treatment options. So I'd just like to introduce them, and then I will turn it over to them to do their presentation. Dr. Wishart is a pediatric physiatrist with a focus on acquired congenital and traumatic brain injury, as well as the role of rehabilitation in the acute care setting. He attended Lehigh University, focusing on a degree in ecology. Following this, he moved to Philadelphia and completed a master's degree in medical science. He then attended Philadelphia College of Osteopathic Medicine for his medical degree and completed a teaching fellowship while there in manual therapy. For his postgraduate training, he went to Thomas Jefferson University Hospital and Nemours Alfred I. DuPont Hospital for Children for a combined residency in both pediatrics and physical medicine and rehabilitation. He's board certified in both pediatrics and physical medicine and rehabilitation, and will be pursuing specialty board certification in pediatric rehabilitation medicine. He's been working on building a more cohesive rehabilitation program at the Mass General Hospital for Children, as well as integrating into several of the outpatient multidisciplinary clinics, including the leukodystrophy, neuromuscular, pediatric stroke, and hemophilia clinics. I hope I said all of those correctly. He is also providing outpatient services at Spalding, Charlestown, and Salem. When home, he loves to get his 2 young daughters and son outside as frequently as possible. The joy that he finds in the outdoors fuels his practice by working to get his patients back out doing the activities that inspire them. And we also have with us Dr. Emily Kivlehan. She is a current pediatric rehabilitation fellow at the Spalding Rehabilitation Hospital of Harvard Medical School. She graduated from medical school from the Georgetown University School of Medicine, where she was inducted into the Alpha Omega Alpha Honor Society. She completed her physical medicine and rehabilitation residency at the McGaw Medical Center at Northwestern University Shirley Ryan Ability Lab. Her specific clinical interests include cerebral palsy, infant rehabilitation, and early diagnosis of cerebral palsy and spina bifida. So we are very lucky to have two such excellent experts with us today. And so I am going to turn it over to them for their presentation, and thank you very much. Go right ahead.
Thank you, Jean.
Hi, everyone. Thank you for joining us today. So we are going to talk about scoliosis, specifically in our children who have spina bifida. We have no disclosures. So to review the talk, we'll start by reviewing what is scoliosis. We'll talk about how we diagnose it in children, talk about the specific things to consider for scoliosis in a child with spina bifida, and also talk about what we can do to manage scoliosis. So starting off by what is scoliosis? So we define scoliosis looking at the anatomical plane which the spine curvature occurs in. So we divide the body into multiple planes. So for scoliosis, you actually have to have a curvature in 2 planes. So typically you have one in the frontal plane, and then you also will have a rotation. So it's a multiplanar deformity. You also have a kyphosis, and the amount of kyphosis is expected in the thoracic middle of the spine, so kind of that hunching over. So you can have excess kyphosis, but it's also expected to have some amount of kyphosis in the spine. Lordosis, again, we're expected to have some amount in the spine. Here you can see in the lumbar spine, this picture is a patient with excess lordosis. So we want some, but you can also have too much. Moving on to diagnosis. So we start, like everything else, just with our physical examination. So we can observe the patients in different positions, so seating, looking at their curve when they're standing, looking at their curve when they're laying down. If your spine is curved, it can also kind of pull your pelvis to be curved, and that can pull your legs to be uneven, so we can look for leg length discrepancies. We can look for changes in the range of motion or flexibility in certain positions. And then the classic test that we do for scoliosis is the Adams forward bending test. And this is that test that all the nurses and schools will do to screen for scoliosis. So to do that, the patient stands with their feet about 15 centimeters apart, and the examiner is behind them. They flex at their trunk, so they bend over. They let their shoulders and arms just hang loose, as you can see in the picture. And if the spine is rotated and curved, they'll have this hump that you can see. So on the far side of the screen, you can see that because of that spine rotation, you can identify a little bit more easily that the rib cage is off and there's probably a curvature in the spine. We also use imaging, of course. So we'll do x-rays. We prefer to have weight-bearing x-rays. So ideally, you'll be standing. But of course, not all of our kids with spina bifida can stand. So that's okay. If they can't stand, then we try to do seated. And if they can't sit, then we'll go to laying down. But that's kind of the order of our preference. They do two different types of x-rays. So they want one just from the front. So that's called a PA x-ray, a posterior anterior. And then they also do it from the side, which is just a lateral view. And then to measure the curve, we use the Cobb angle. So that's where you'll get your 45 degrees, 60 degrees. And to do that, the radiographer or the physician will find the vertebral bone that's the most curved. So here you can see they identified that as T11. So that one is really curved. And the T5 is also very tilted. And then they make parallel lines to those bones, and the intersection of those parallel lines gives you your Cobb angle. So that's a term that you'll hear. And then we also want to see the skeletal maturity, as that has important implications for our next steps in scoliosis. And it's a little bit difficult to tell the skeletal maturity in the spine. It's a lot easier to look at the pelvic bones. And the pelvic bones mature at a pretty similar rate to the spine. So we'll go ahead and look at the pelvic bones and we get something called the Risser index. And that's just kind of, we see the growth plates and how they're moving, and it can tell us how mature the spine is skeletally at that point. And so more descriptors that you'll hear is where in the spine. So we have four parts of our spine. So that pink area is the cervical spine. That longer yellow area is the thoracic spine. The lumbar spine is the green part at the bottom. And then the blue is the sacral part of the spine. So the descriptors will go where the curve is starting and where it's ending. So something, like a T2 to an L3, that whole just means that whole area is involved. And then some curves are an S-shaped curve, as you can see on the far side, and then some shapes are C-curved, and we'll talk about that later, but in the type of scoliosis that spina bifida patients get, it's more commonly a C-curved. And these pictures are a little bit lying, because another thing that we'll also talk about is that the pelvis is probably going to turn as well. So here the spine is going to the pelvis and the pelvis is still aligned nicely, but more likely that pelvis also becomes involved, especially with those C-shaped curve, which has some important implications to know. And then they'll also describe which way it's going. So is it going to the left or going to the right? So levo or dextroscoliosis. So what about scoliosis in spina bifida? So spina bifida, it will really depend on the level that is involved with. So if they have just a sacral or a low lumbar, they're going to be less likely. But the more trunk that's involved, the more likely their spine is going to be involved. So in a patient with an L5 myelomeningocele, only about 25% will develop scoliosis, which makes sense because that weakness is starting a lot lower in the spine. But if you have an L1 or even a thoracic level, it's a lot more likely that there's going to be some scoliosis because more of the spine is going to have weak muscles around it. So why does this happen? So we kind of talked about this a little bit in the last slide, but that weakness is the main issue. So as you're weak, you go into an abnormal posture because you can't really fight gravity. So your body will kind of just go into that comfort and let gravity kind of win. And that allows these asymmetric pulling of these growing bones that can cause this curvature to be a little more permanent as that asymmetric force continues. And another thing that happens more commonly in spina bifida patients or neuromuscular patients is that because they have that weakness, they kind of start to collapse moving forward, kind of like that hunched forward position. So they're also more likely to have that component of it, of the hunching forward, as well as that sideways scoliosis. And so just to review about the types of scoliosis, so idiopathic and adolescent idiopathic scoliosis, sometimes called AIS, that's the most common type of scoliosis. It most commonly happens in adolescent females. There can also be a congenital scoliosis, and you can see this picture here. So that's patients who were born with something like a bony deformity, like only half of one of their vertebral bones forms, and that results in a scoliosis. And then there's neuromuscular scoliosis. So that compiles patients with cerebral palsy, spina bifida, polio, SMA, all types of neuromuscular diseases. So that is where spina bifida will land. And that can be a little bit different because it tends to be more involved. So it'll often involve the entire thoracic and lumbar spine. So it can be longer than some of those congenital or idiopathic ones. And like we talked about before, because it's often going to be that C-shaped curve, it's usually going to pull that pelvis and make that pelvis be involved too. And we call that pelvic obliquity, that the pelvic isn't sitting normally, it's pulled to one side. And it often will present earlier in life than an adolescent idiopathic scoliosis would, and it tends to progress more rapidly. Oftentimes during puberty, it will progress really quickly. And something that's really common with the idiopathic scoliosis is once you hit skeletal maturity, that's often it. It's not going to continue to get worse. But for patients with spina bifida, that scoliosis is still going to continue to progress even after their bones have matured. So there's more implications than just the spine, right, and just positioning. So if your spine is curved over into a C, that means we have these two lungs, right? So if it's curved over, then one of those lungs is going to be getting kind of compressed and have a little bit less space. And some of your other organs will have a little bit less space. So you can have respiratory compromise amongst other internal issues. That pelvic obliquity, because you're no longer letting that pressure even on a seat, it can cause pressure sores or difficulty with wheelchair positioning if one of your hips is kind of pushing out towards the side. So that's something that we need to be really careful about. Because you're not positioned appropriately, you can cause pain and kind of some pressure on certain joints and areas in the body. And then there's a lot of other concerns that can happen with that spinal compromise. So we can have nutritional deficiencies, impaired respiratory function, cardiomyopathy, GERD, constipation, bladder issues, which I'm sure a lot of the other talks in this series will review in more detail. I'm going to hand it over to Dr. Wishart to continue the talk.
Great. Thank you, Dr. Kivlehan. So I think that this has been a nice overview of kind of what the background of for neuromuscular scoliosis is. And we'll talk a little bit about one of the very specific complications that can lead to some scoliosis related to spina bifida in particular, and then go through some of the management aspects of this. One thing I did want to say about some of the other associated issues is there has been a few studies looking at these nutritional deficiencies and potential weight loss when we have severe scoliosis. And there's at least one study out there that does show after fusing, children having an increase in their weight and normalization of that weight. So we classically talk about respiratory compromise, cardiac compromise with our severe curves, but there's some growing literature that it may be more affecting really everything throughout our truncal area and our core, including our digestive system. So one of the things that we can potentially see in our spina bifida patients is this syringomyelia or syrinx. It's typically thought to be due to an increased pressure of the CSF that gets pushed into kind of the center of the spinal cord. And what you'll see is you end up seeing this upper extremity involvement that may not have been there prior and probably was not there prior. And they may have motor or sensory deficits and just changes in their function in areas that were not typically associated with her original injury. They may have some deterioration of their overall neurologic function and how they're mentating, how they're interacting, and just not acting like themselves. We also may see some spasticity, which may not be typical for these patients. You know, we typically think of this as more of a lower motor neuron where it's affecting the nerves after they've come out of the spinal cord. And we get more flaccidity and kind of weakness and not much tone. But you may see some increased tone in these patients. And with that, what can come is sort of a rapid new onset scoliosis. You can imagine if we have a lot of weakness in our trunk and we don't have that positional control of our spine, if we start to put on some abnormal forces such as spastic tone or increased muscle tone in some of those muscles, we can pull ourselves into a pretty rapid progressing scoliosis. And so this is something to keep an eye out for. And if we see rapid kind of new onset changes, something to look for. So in terms of our management, we'll talk about it sort of on a spectrum. There's a lot of different options and a lot of different aspects to managing neuromuscular scoliosis. And unfortunately, it's not really a cookie cutter type of disease that we can just follow straight through. There are some outlines and some protocols that you can follow that say, do this once it's diagnosed, and then when you have this number, you do this, and so on and so forth. And I think that works really well for our adolescent idiopathic patients. But when we start talking about the neuromuscular and there's a difference in terms of that muscle tone, it really does change how we have to manage this. Additionally, there's often a lot of other complications and needs that the patient has. So really, our options range from observation all the way to really invasive surgery. In the middle there, we have some bracing and potential for therapy. The unfortunate part is that we don't have a lot of literature saying that's going to do a lot to help, which we'll get into. So things that we think about when we're talking about how much and when we should be doing each of these, the main thing that we really talk about is the degree of the curve. So obviously a very minor curve, we wouldn't want to do a very invasive surgery. So under really classically, they say about 20, 25 degrees, we're going to just continue with observation for these patients and just monitoring regularly with frequent x-rays. Again, the challenging part with neuromuscular scoliosis is the rate of progression. It can go from not really changing much to a very rapid progression. So it's not a very linear change. Once we get past that, we do talk about bracing and then surgery as well. And surgery starts being in consideration in our neuromuscular patients by about 35 degrees. I will say that that's often not the case. We typically, I can't say I've seen a ton of patients go for surgery as early as 35 degrees, and it often gets pushed off much later. But we should be considering surgery when it gets to that point due to that rapid progression. And we'll talk about some other reasons for that as well. So in terms of therapy, there are a few options out there. Typically, we're working on maintaining our range of motion. We're working on stretching and other aspects of our function. One of the big things that we want to make sure that we're doing with this is preventing contractures. Any sort of lower extremity contracture or anything that's going to affect how we're positioning ourselves is going to set us up for an increased risk for progression of scoliosis or development of scoliosis. Our equipment needs and how we use those and how they fit are a huge part of management, particularly beforehand. We want to make sure that we're keeping that pelvis and that our sitting bones nice and even and as they're supposed to be. So having a good seating option for our patients that are in a wheelchair or using a wheelchair at any point is a really important part of this. For our younger patients, as they're developing their bone strength and they're still growing, having a standing option is a big part as well. And again, all of these things need to be appropriately fit. They need to be managing the patients in the appropriate way and keeping them in a good alignment. There are some specific scoliosis exercises and therapeutic or therapy models. They're not specifically for neuromuscular. Most of them have been designed and and brought out for adolescent idiopathic scoliosis. And it's really unclear if there's any role for these in terms of neuromuscular scoliosis in decreasing our curve progression. Much of what we have on the non-surgical aspect of neuromuscular scoliosis is not affecting our curve progression, and that's one of the hard parts for this. But they're out there, and I think that there's a potential role to at least improve some of the other aspects that come with this, whether that's pain, function, range of motion. It may be something that we should be looking for moving forward, and they may have those other benefits, and really they're unlikely to have much harm. So this is a fairly comprehensive list of a recent review of the different therapy models that are specific for scoliosis. And as you can see, I thought there was one. Well, so most of them, as you go through, if you dig in, I think it's within this principles of correction and the age is treated, you can get a sense for what type of scoliosis they're going to be treating. And realistically, as you read through the paper, they're all for adolescent idiopathic scoliosis. There may be some that focus a little bit more on neuromuscular components and muscle activation. You know, the hard part when we read that is when they talk about neuromuscular re-education and that sort, they're talking about muscles and nerves that are working 100%. And you know, typically when we have these abnormal innervations and function of our nerves, it makes it a little bit more difficult to re-educate those nerves in a way that'll change the scoliosis. So I think there's a role for these. The Schroff method, I think, is one of the more classic ones that I had heard of, but there's a number more that are out there, and something to think about as we're going through. So again, not much literature, if any, to make them useful in terms of neuromuscular scoliosis. Bracing is kind of our mainstay for our non-op treatment in terms of scoliosis, particularly when we talk about that idiopathic one. One of the big things, and again, this is the important part of neuromuscular scoliosis, and something to know as we're going through, is that bracing is unlikely to halt the progression of neuromuscular scoliosis. So when we talk about our dose time or how much we expect a patient to be wearing a brace as they're going through the day for decreasing the progression of that curve, it's really in the range of 22 to 23 hours a day. Really, you're taking it off to bathe and you're putting it back on for the rest of the day. For a lot of these kids that have other comorbidities, other medical needs, this can be really challenging and it can be almost unrealistic. And the reality is when we look at our neuromuscular patients, even if we are wearing it 22 to 23 hours per day, it's not necessarily decreasing that progression. So putting our kids through, you know, the difficulty and the hassle of wearing this for 23 hours a day, sleeping in it all day, just to have it progress anyhow, I think is something that we really need to consider when we're discussing how we're going to be using the brace and what type of quality of life and what type of goals we're going to set when we're using this. So when we talk about bracing, and we can go back to just the basics of bracing, really our goal is to apply this balanced force. So you can see these three arrows. One is directly at the vertex of the curve, and then we have two other forces pushing on the opposite side. And you can imagine how that will help to balance that curve and prevent it from moving any further. There is some evidence that depending on where we are on that curve, we can actually improve the stability of it. And I think you can imagine that the further you get, the more likely and the more uneven those forces are. So a much wider curve is going to be pushing down on either side and putting it into a bigger scoliosis. And you can see here, and what these 50%, 80% stability actually mean, I think is slightly unclear. But a decreased curve from 45 to 30 degrees is more stable. And same thing, from 30 to 20 increases stability to 80%. So the less of a curve, the more stable that spine is. So I think that's one of our goals as we're going through this. If we can help decrease the progression, it would be great. But the other side is what our other goals for bracing. And I think one of those main things is going to be comfort. It can be positioning and allowing that patient to be more upright. You can imagine if we have a big C-shaped curve, often it includes our pelvis, but can come up into our cervical spine and affect how our head control is and positioning. And it can make it difficult to do our daily activities of daily living, from, feeding, getting dressed, eating, communicating, and keeping, good eye contact with their head nice and straight. So there are different goals when we talk about bracing that are not just progression of the curve. We do have a number of different braces out there, all named after where they were developed. So there's a Milwaukee brace, which is one of the original ones. This definitely has the best control. And when we talk about our kids with a C-shaped curve that is affecting that cervical spine, this becomes tempting to think about using, as it's one of the few things that we're going to have control over that C-spine and the upper thoracics. It does anchor under the chin and all the way down to the pelvis. And it is the most successful in terms of affecting outcomes and preventing progression, though at this point it's a bit outdated and we really don't see this used as much, particularly for our neuromuscular kids, where what we found is that it's that underlying muscle disease that's causing this progression of the curve. And it's probably going to progress despite us putting a patient in this. So this is the Milwaukee. More likely and the more common braces that we see out there are TLSOs, or thoracic lumbar sacral orthoses. Not as effective if that vertex or that peak of the curve is above T8, which is kind of halfway between our nipple line and our belly button. So if it's above there, this really doesn't necessarily do a great job of controlling the curve, and you can see patients kind of falling off the top of it. But there are a couple different types out there. There's the Boston brace. This is a prefabricated brace that then gets customized to the patient by adding components, but like pads with inside to apply forces. And then there's the Wilmington brace, which is more of a custom molded TLSO, but also has those force pads. And you can see how specific you can get with this, versus this girl on the right side has a very high aspect coming up into the axilla or the armpit on the left side of her, trying to really control that curve up high and then grabbing the pelvis on the low side. So her curve probably comes kind of from the left side of her pelvis over to the right and back. And so we have that force here and on either side. Again, they're not necessarily decreasing the progression. So a lot of what we're going to try to do with this is help with positioning, with comfort, with function, and see if we can increase the amount that the patient's able to do by putting them in a better position. There are some cervical or surgical options out there, and this is what we do as the curve progresses. As you can see from the pictures on the right, this is definitely not a 35-degree curve, which is really relatively minor. We're probably pushing somewhere around the 90 plus degrees here. And so often these surgeries do take place at a more advanced time in terms of the scoliosis. We have very clear cutoffs when it comes to adolescent idiopathic scoliosis. At 25 degrees, we're going to start to brace, and usually at 40, 45 degrees, they'll plan for surgery depending on how old that patient is. That's because it stops progressing when they hit skeletal maturity. Again, we don't stop progressing in our neuromuscular patients at skeletal maturity, so it makes that decision a little less clear. Often what we have to take into account is what are the goals, what is the underlying disease process. For spina bifida, there's not necessarily a significantly decreased length or life expectancy. So that's something that may not come into effect when we talk about spina bifida, but I think the question is, what is our function and how are we doing with just our bracing? Are we able to maintain our positioning so we can function? Do we have other comorbidities or medical issues that would make surgery much more risky? And what will the benefits be in terms of doing the surgery? And how will they tolerate it? If they do need surgery due to this neuromuscular component, typically it's a pretty big surgery. So often we see patients getting fused really from the upper aspects of their thoracic spine all the way down into the pelvis. There is some discussion of whether it should be including the pelvis, but for the most part, I believe most surgeons think that we should be stabilizing into the pelvis to make sure that we're not having this pelvic obliquity get, contribute further to ongoing scoliosis after we've had the fusion. The recovery time can be pretty prolonged. It's a big surgery, and often it's done in staged process where there maybe need to be 1 or 2 surgeries. But we do talk about, from after the surgery, it being potentially up to a year before patients are back to their baseline from when they went in, and then improving from there. And so with this kind of large surgery, with this big change in terms of how our muscles are functioning and how our spine is sitting, often an admission to an acute inpatient rehabilitation facility can be appropriate following the surgery. And that, the time there is to help work on some of the medical management in terms of pain, how to manage bowel and bladder now that things have changed, making sure that our wounds are healing well, making sure our pain is well controlled, and then also focusing on the function and working with our physical and occupational therapists, working with our speech therapists in terms of how to do things now that, really the whole body is functioning likely differently after we've realigned the spine and changed the mechanics of it all. So looking forward, I think, this is one of the big questions. So multidisciplinary teams, I think, are crucial to the care of children with spina bifida, and I think it's just as important when we talk about scoliosis. Often this gets put solely on the orthopedic surgeons, but I think that making sure that we're appropriately setting our goals and thinking about the function of the patient and what we're going to get out of it are key, and that's something that our physiatrists can be helpful with. When we look at, other causes like our C-rings and possibly a tethered cord that can be contributing to the scoliosis, it's important to potentially involve our neurosurgeons. So really involving the full team taking care of our patients with spina bifida, I think, is important. Something that we see often in our children, but as our patients grow and they age out of those kind of multidisciplinary clinics, it's less common in the adult population, and I think it's something that we should be putting together, and if possible, even putting together for yourself, where you have a team that you're able to help communicate and facilitate. There's really no perfect prescription. This is very patient dependent, and those numbers of when to go for surgery, when to use the brace, how often to use the brace are specific to the patient. We may not have a very clear-cut answer of at 45 degrees you go for surgery, because it may be well managed with that brace, and there may be other comorbidities that are contributing at this time that it makes it less appropriate. Or we may be seeing rapid progression, and we think that it's going to progress much quicker than expected, and we should be doing it at 40 degrees or potentially less. So I think that the challenge with when to do that surgery is real, and it should be an ongoing conversation with the different people on the team. And again, open communication with the family, with the patient, of what their goals are and what their fears and what potential benefits and risks come with the surgery, as well as that goal setting is important. I think there are a few goals and hopes that I have for the future in terms of the management of our neuromuscular scoliosis patients. One would be improved therapies. We have some of these therapeutic models that are specific for adolescent idiopathic scoliosis, but there's really no proven outcomes when it comes to neuromuscular scoliosis. And I think trying to take a look and see if there's anything that we can be doing, even if it's from a very early stage, when we talk about that stability of that spine, if we can try to prevent any sort of curvature from beginning, would it potentially help us prevent that progression and not potentially go on? I don't know the answer to that, but I think it's something that we should be looking for and looking into. I think same thing with our bracing. Right now, we don't have a good option in terms of preventing that bracing or preventing that progression with bracing. We do a good job, I think, in terms of maintaining our posture and helping with how we're functioning on a day-to-day basis. But I think there's more that we can do in terms of our non-operative and less invasive treatments as we're going through. And then again, I think posterior and our spinal fusions all do a wonderful job, and we've had some really nice progression in terms of growing rods and other things that we can do to help prevent ongoing surgeries. But there are some other surgeries out there, such as tethering and less invasive surgeries that are being used for idiopathic scoliosis. And I'd love to see these looked into for our neuromuscular patients and see what we can do to try to help and prevent these really long, prolonged recovery periods. So I think that is the gist of neuromuscular scoliosis. I hope that's helpful. And Thank you.
I just want to say thank you to both of you. This was really fascinating. I think, we talk all the time in our community about spina bifida being the snowflake disease or condition because the impact is so different on every different person depending on where the impact to their spine is. And you did such a good job of outlining that and really making it very clear what the different, really multi-system impacts can be depending on, again, on where the anomaly falls. And so I just think the comprehensive look at, again, the multi-system impacts of all of this is really, really helpful. So I think this is going to be tremendously valuable to everybody in our community, especially parents of young growing kids who are approaching these kinds of decisions and considerations as their children develop and their spines are growing. I think this would be really, really helpful, and I really appreciate your time and your expertise so much. This is a great asset for us. So thank you both so much for taking the time to join us today. And hopefully we will see you in person next October when we're able to have our regional conference.
Yeah, that would be great. Thank you so much. I really appreciate it. And it's an honor to be part of the community.
Well, wonderful. Thank you so much.
All right.
Take care.
Thank you.